Good morning, ladies and gentlemen. In this 20 minutes talk, I'll be talking about why we choose a map of more than equal to 65 millimeter mercury, which has become a standard in our management of septic shock patients. So if we look at the septic shock, it is defined as sepsis with hypotension, which is refractory to fluid challenge and requires vasopressor. There's an increase in arterial lactate reflecting impaired cellular energy metabolism and dysoxia. So the lactate more than equal to 2, along with a refractory hypotension, which is, you have done fluid resuscitation, but patient is still in shock and requires vasopressor support, is classified as septic shock. And when we resuscitate these patients, we are basically trying to restore the tissue perfusion pressure. And at the same time, we don't want to cause excessive vasoconstriction, which will impede the flow and paradoxically worsen the organ dysfunction or may lead to other adverse events. So when you look at the mean arterial pressure, here you can see in this cartoon, we have two components. The heart has to pump blood against the systemic vascular resistance, which is largely because of the larger arteries. So the map has been defined as cardiac output into systemic vascular resistance plus CVP. For most calculations, we take CVP as near zero, near normal. So it basically translates into map is equal to cardiac output into systemic vascular resistance. So that gives us a physiological basis of mean arterial pressure. However, when you look at the way we calculate it practically, how your monitor does it for both non-invasive as well as, otherwise. So mean arterial pressure is the diastolic pressure plus 1/3 of the systolic minus diastolic pressure difference, or 1/3 of the pulse pressure. Now here in this arterial aortic waveform, you can see, now this is an aortic pressure here on this side, and this is the time, 1 cardiac cycle. So this is the dicrotic notch here. This is the peak of systole, and then you have the diastole. So the pressure here would constitute the mean arterial pressure here. And also you can see here in the right-sided cartoon that when systemic vascular resistance, this is the normal mean arterial pressure, cardiac output and mean arterial pressure relationship. When SVR increases, the mean arterial pressure increases. When SPR decreases, the mean arterial pressure decreases. So it's a key component of tissue perfusion, and often we consider it as a surrogate of organ perfusion pressure. And both are the Society of Critical Care Medicine and the European Society of Intensive Care Medicine guidelines suggest that we need to keep MAP more than equal to 65 millimeter mercury and individualize this target based on comorbidities. Now, there are some concerns here. We know vasopressors we give commonly to patients who are in septic shock to avoid hypotension, which may be associated with myocardial injury, kidney injury, or death. But our concern is that vasopressors may reduce the blood flow in vasoconstricted vascular beds. They may have adverse effects on cardiac, metabolic, microbiome, and immune functions. So when we are treating septic shock and trying to maintain a MAP of more than equal to 65, we have to strike a balance between the risk of hypotension and the risk of vasopressors. So that continues to be a big challenge. Blood pressure most of the time is used as a guide. Mean arterial pressure is used as a guide for targeted vasopressor therapy. But the opinion has changed over a period of time. If you look at the 2012 surviving sepsis guidelines, the things were very, very clear. The target MAP of 65 millimeter mercury with a higher target for older patients and those with chronic hypertension and coronary artery disease. So 2016, when you see, they acknowledge that there is no evidence now for good evidence for targeting MAP values more than 65 in any patient groups. So that means we are still not very clear as to, we should target 65 or we should target more or we should individualize this therapy. So this talk will dwell on these aspects and will also focus on the research that has been done in these areas. some of the studies, large scale, these were New England Journal studies, they found that MAP exceeding 65 millimeter mercury was frequently observed in large prospective randomized controlled trials, which were basically resuscitation trials focusing on septic shock. So these data suggested that patients had MAP in the range of 75 to 95, 24 hours after inclusion. So it's not uncommon to have a higher MAP in the, even in these high-class research settings. Then we had a large retrospective study published in Intensive Care Medicine, which showed that a MAP of more than 75 millimeter mercury may be required to maintain the kidney function. So should it be higher than 65? That is the big question. Well, higher blood pressure can be useful. This was confirmed by a smaller prospective observational study published in Critical Care. And then another perspective was given in the study published in BMJ, where they looked at, it was a physiological study looking at mechanism of chronic arterial hypertension, which showed that such hypertension causes a rightward shift in cerebral perfusion pressure and flow autoregulation, which might justify targeting a higher MAP in these patients. Now, this, when you look at this cartoon, now this is the normal relationship in healthy individuals. This is the autoregulation. This is organ blood flow on the y-axis, and you have here the blood pressure. So, this is autoregulated nicely here, so that the cardiac output and other things remain same, and the organ blood flow remains same. And in chronic hypertension, it gets shifted to the right, as was suggested in the previous study. However, this may be lost in patient relationship, or autoregulation may be lost in patients who are in septic shock. So you see a linear relationship. So as the MAP is rising, you can see that the organ blood flow is rising. There is no autoregulation here. So autoregulatory mechanism is impaired in septic shock. Increased blood pressure will increase the organ blood flow. And another important thing is autoregulation will depend on the basal level of blood pressure, which will be higher in patients who are hypertensive. So optimal MAP target may differ, logically speaking, according to patient's medical history. So generally, when we are targeting a high MAP, the perfusion pressure increases and the venous circulatory pressure reduces. So if we look at the current surviving sepsis guidelines for vasoactive management, we use norepinephrine as the first-line vasopressor, and we target a MAP of 65 millimeter mercury. And of course, we will also consider invasive arterial monitoring of the blood pressure. And plus, the consideration now is that do not allow patient to be hypotensive. Do not wait for fluid resuscitation to be over and then start your vasopressor. So consider initiating vasopressors peripherally and simultaneously with fluid resuscitation. And then once central access is available, you can make a switch. Let us look at the evidence. So this was the sepsis-SPAM trial, the famous sepsis-SPAM trial, published in New England Journal, where they looked at high versus low blood pressure target in patients with septic shock. So this was a multi-center open-label trial where 776 patients with septic shock were randomly assigned to undergo resuscitation, either with a mean arterial pressure target of 80 to 85 or 65 to 70, which was considered a low target group. Primary endpoint was mortality at 28 days. The target mean arterial pressure was to be maintained for a maximum of 5 days or until the patient was weaned from vasopressor support. After that, target pressure was decided by the attending physician. Secondary outcomes in the study included 90-day mortality, days alive and free from organ dysfunction by day 28, and length of stay in ICU and hospital. So you can see the mean arterial pressure during 5-day study period. So this was the low target volume, low blood pressure target group, and this was the high MAP target group. And you can see the difference in the MAP. So this was between 65 and 75, and here it was higher than 80. So 85 to 90, that is what you see here. And If you look at the Kaplan-Meier curves for cumulative survival, you find that there was absolutely no difference in terms of survival, 28 days, 60 days, or 90 days. So the study concluded that in patients with septic shock, 28-day, 90-day mortality did not differ significantly between those who were treated to reach a target mean arterial pressure of 80 to 85 versus those where the target was 65 to 70 millimeter mercury. So essentially saying that targeting a higher MAP is not that bad. Another study from Canada looked at higher versus low blood pressure targets for vasopressor therapy in shock. Now, this was a multi-center because of the small number. This was a pilot randomized controlled trial. And this was called the OVATION trial, Optimal Vasopressor Titration trial. The study design was published earlier. So what they did, they randomly assigned critically ill patients in vasodilatory shock, whatever was the diagnosis, to either a lower MAP, that is 60 to 65, or a higher MAP that was 75 to 80 millimeter mercury. Primary objective here was to measure the separation in MAP between the groups. And they also looked at risk of cardiac arrhythmias, which they found was, 20 versus 36. It was percent. And hospital mortality were not different between the lower and the higher MAP arms. In patients aged 75 years or older, they found a lower MAP target was associated with reduced mortality, but such an observation was not found in the younger patients. This pilot study supported the feasibility of a larger trial comparing MAP targets below those applied in the sepsis-PAN trial. So sepsis-PAN, as you have seen, focused on the normal 65-70 target versus 80-85 target. Now here they say that even the lower values are better in patients who are aged more than 75 years. And they also say that further research may help delineate the reasons for vasopressor dosing in excess of prescribed targets and how individual patient characteristics modify the response to vasopressor therapy. That means we are still not sure whether it should be age-based or it should be individualized, or it should be one, single value of 65, because we found less is also good and more is also good. There was another recent trial. This was published in 2020 in JAMA, where they looked at effect of reduced exposure to vasopressor on 90-day mortality in older patients who were critically ill and they were in septic shock. This was a randomized clinical trial, and they wanted to determine whether reducing exposure to vasopressor through permissive hypotension, so the same values that the previous trial had, Canadian trial, 60 to 65 millimeter mercury, reduces mortality at 90 days in ICU patients who are 65 years or older with vasodilatory hypotension. It was a pragmatic, open, multi-center, parallel group, randomized clinical trial that was done in UK, 65 NHS hospitals, which included general intensive care units. And patients who were more than equal to 65 years were admitted to these participating ICUs if they were eligible, and they were randomized within 6 hours of initiating a vasopressor infusion for vasodilatory hypertension with adequate fluid resuscitation to either the MAP target group of 60 to 65 millimeter mercury, which was called permissive hypertension. It had 1291 patients, or according to usual care. That is, it was left to the discretion of the treating physician, almost 1,300 patients. And the primary clinical outcome was all-cause mortality at 90 days. They had a lot of secondary outcomes. This study was called 65 study, famously called so. Secondary outcomes were mortality at discharge from ICU and from treating acute care hospital, duration of survival to longest available follow-up, duration of advanced respiratory renal support during ICU stay, days alive and free of advanced respiratory support and renal support within first 28 days, duration of ICU and treating acute care hospital stay. They also looked at cognitive decline as well as health-related quality of life. So when you look at the results, they found targeting a lower MAP in permissive hypertension group did not significantly increase the number of hours with a MAP value lower than 60. At 90 days, there was no statistically significant difference in all-cause mortality. Mortality at ICU and treating acute care hospital discharges were not significantly different. And there was no significant difference in time to death between the groups. The mean duration of ICU and treating acute care hospital stay and duration and days alive, free from advanced respiratory and renal support to day 28 were not significantly different. Number of serious events, adverse events were again not statistically significant. So they did not find any difference either in mortality or in secondary outcomes, ICU stay, respiratory, renal therapy, or cognitive and other dysfunctions. So here you can see the Kaplan-Meier survival curve. So practically this study meant that reducing exposure to vasopressors through permissive hypotension did not significantly reduce mortality at 90 days. Now it is up to us to interpret it either way. So basically all the trials that I have shown so far, we found that targeting, if you look at the sepsis trial, targeting a higher MAP was equally good. If you look at the Canadian pilot study, targeting a lower MAP, 60 to 65 was good in patients more than 75 years, but they said that we need to validate the data in a larger series. Now here you find that if you are doing permissive hypertension 60 to 65, the Canadian target, then it does not significantly reduce mortality at 90 days. So it doesn't really help. There was a meta-analysis which was published in Journal of Clinical Medical Research this year, and they looked at the randomized controlled trials. So a lot of these trials were included up to 2020. And if you see when they are looking at the overall mortality, there you find that the diamond is very close to the baseline, and there are only 5 or 6 trials which fit into the scheme. So possibly we cannot find an answer, although it seemingly looks to favor a standard MAP. So what they have concluded here is targeting a high MAP goal in critically ill patients offers no benefit over current standard MAP goal in terms of mortality, duration of mechanical ventilation, and ICU length of stay. Another, data was published by Maheshwari et al. They collected data from the electronic health records retrospectively, and they looked at the association between MAP and acute kidney and myocardial injury, as well as in hospital mortality. All these patients were in septic shock. So they had a data of about 8,700 patients from 110 US hospitals. They define total exposure to hypotension as time-weighted average MAP and calculated cumulative time spent below 55, 65, 75, and 85 millimeter thresholds. So what they found was exposure to hypotension, that is, time-weighted average MAP below 65 was directly related to hospital mortality. The longer time spent below MAP of 65, this TWA MAP below 65, the higher risk of mortality, acute kidney injury, and myocardial injury was there. The risk of mortality, acute kidney injury, and myocardial infarction were apparent at 85 millimeter mercury. So what this exploration of the electronic health record database is suggesting that below 65 is harmful, above 85 is also harmful. My final concluding remarks is, MAP may be a relevant goal for improving outcome in septic shock, but although in general, a low MAP strategy seems to be similar to a high strategy in terms of outcome, a single fixed value is not suitable for all patients. Optimal blood pressure target likely ranges from 65 to 85 millimeter mercury and probably lies between 65 to 75 in most millimeter mercury in most patients. Whether an individualized based approach will result in better outcomes than a protocol based approach, targeting like we do currently a predetermined level of MAP remains to be demonstrated. And one very important thing is it is not only about macro circulation. If you remember, although we don't believe in the EGDT reverse EGDT trial, but the microcirculation cannot be ignored when you are looking at the mortality and you are only looking at correlation of the MAP with mortality, 28-day or 60-day mortality. So I think more pragmatic study would be that includes the macrocirculatory targets also, and then separates the macrocirculatory data to say that whether the microcirculatory data and tells us whether the macrocirculatory has an impact in absence of a microcirculatory data. So that possibly will answer. So as of now, ladies and gentlemen, 65 to 75 would be a prudent approach. But I will not disagree with those who would go for a higher MAP in patients who are hypertensive. So the question is very much open as of now. Thank you very much for your attention.